Society of Anesthesiologists, Karachi chapter. I'm your host, Dr. Azhar Rahman, working in Department of Anesthesia at Aga Khan University. Today's topic is very interesting and important, which is updates on postpartum hemorrhage, major obstetric hemorrhage, and update. We are lucky today we have Dr. Jodat Saleem with us. He has a multi-dimensional personality. He is an eminent perioperative and critical care physician, a keen researcher, and an outstanding educator and administrator. He is working as a professor of anesthesia and critical care at Postgraduate Medical Institute, Lahore General Hospital. He is the current president of Pakistan Society of Anesthesiologists, Lahore chapter. He is also a supervisor of anesthesia and critical care medicine program at CPSP. He is also an executive member of MS program in anesthesia, and he worked hard for the provision of critical care in remote areas as well. And he established first ever ICU in Sahiwal at District Hospital. He also established a state-of-art ICU in PGMI, Lahore General Hospital. Beside all these clinical activities, he always remained interested in research as well and has more than 20 research articles published in peer-reviewed journal. During the COVID-19 pandemic, as a frontliner, he worked as COVID in charge at Lahore General Hospital, and he was the organizer secretary for South Asian Association for Regional Cooperation Association of Anesthesiologists in 2019 that was held in Lahore, and that was a major successful thing. Um, I will request all the participants to please keep your devices on mute mode. And if you have any question, any query, you can ask through the chat box. So we welcome Dr. Jodat. You can start now, sir.
Thank you very much, Azhar. Assalamu alaikum, and a very good evening to all the participants who have spared some time to join this meeting. And first of all, I would like to thank PSA Karachi for providing me this opportunity to interact with you on this topic of great concern. So why I opted for this topic? Azhar, ये थोड़ा सा स्लाइड मूवमेंट में प्रॉब्लम हो रही है मुझे.
Okay.
Got it. ठीक है. Yes. Okay, so this is something which is very important as far as if we talk about the examination point of view. So this is a mandatory part of the Viva's theoretical portion in your DA exams, MCPS exams, FCPS and MS examination. And apart that, it is a daily routine. We are coming across with the obstetric patient, either we are working in a public sector hospital or we are working in a private sector hospitals. I'm working in Lahore General Hospital, which is like the first hospital at the entry of the periphery of the Lahore. So it almost covers a referral center for almost 60-kilometer area, and we have various DHQs, THQ, and private clinics. And you won't believe me that hemorrhage, obstetric hemorrhage, is #1 emergency which we are receiving on daily basis in our hospital. So starting with the lecture. So I'm going to cover briefly the introduction and national and international data. And then I'll go through the APH, PPH, and major obstetric hemorrhage, its causes, etiology. Then we'll go through the various steps of management of these patients and how anesthetists can make a difference, can improve the outcome of the patient. And finally, we'll go through the international guidelines and protocols which are practiced these days. And finally, I'll put you a scenario. And after you going through this presentation, I hope you may be able to do it in a better way or to manage these patients in a better way. So I'll show you this video. This is a case which I conducted last year. And this patient bleed 20 liters. You can see the bags. I'll just give you a quick glimpse and just try to focus on the areas. These are the sheets and blood under the table. Now look at the gauze pieces, the lab pads, and have a look on the 2 5-liter bottles which are placed behind these sheets. Then you see this is 3-liter bottle filled, and the other one is the 5-liter bottle. And just have a look on the sheets. Now it's just coming. So this was a 20-liter blood loss. I discussed with the surgeon, who was a professor himself, and we proposed him to go for an early hysterectomy. But they were trying to save the uterus, and finally we ended up with the help of the urologist and a general surgeon. So we were able to save the patient. She was ventilated. She was packed with a couple of sheets, not just gauze, but not enough. And after 48 hours, when she was hemodynamically stabilized, she was reopened and she was somehow managed. So first of all, I would like to ask the participants how much blood loss with a major obstetric hemorrhage with a PPH you have come across in your professional life. So you can write this in the comment chat box. Anyone? What I have faced is a 37 liters of blood loss. The patient went 3 times reopening, and finally she was given factor 7A, and we were able to save the patient. Starting with the major obstetric hemorrhage, it's been one of the leading causes of the maternal mortality and morbidity all over the world. The condition is not just confined to the developing countries, but it is also a problem in the developed countries as well. How will you define major obstetric hemorrhage? Can you write down in the chat box? Any one of you, how will you define major obstetric hemorrhage? What is the definition? You can write in the chat box. I'll see it. Look, listen, I just want to make it a little bit interactive. So can we are just in the interaction in between the presentation. So I can have the idea you are with me.
So from your previous question, I got one response. This is experience shared by Hafizullah. He's saying that 6 liter, but patient not survived.
Yeah, I'm having a look on the chat box as well on the other laptop.
Okay.
So that loss of more than 2 liters. In how much time? Is it a day? Is it an hour or so? Okay. So major obstetric hemorrhage is defined as the acute need of blood transfusion of more than 4 units in 1 hour, blood loss of more than 1500 ml during the procedure, or decrease in the hemoglobin of 4 gram per deciliter. So this is called as major obstetric hemorrhage. Now, major obstetric hemorrhage is one of the leading causes of maternal mortality in the USA, UK, Europe, all the developed countries, as well as the developing countries. There's a worldwide increase in the PPH, even an increased incidence with the previous history of surgeries. You must have noticed it, that there is an increased tendency towards going for the cesarean deliveries these days. So with the increased number in the surgeries, there is a chance that patient might develop this kind of PPH because of placenta previa, placenta accreta, placenta percreta, and things like that. So generally, an estimation is 3 to 5% of all the deliveries, they might undergo a major obstetric hemorrhage. And another alarming figure is every 4 minutes, maternal mortality occurs worldwide. So I'll give you the data later on. Now, hemorrhage remains one of the leading causes of maternal mortality, and this is a data which is given by the confidential maternal inquiry conducted in UK in 2016. So I'll just go through these slides quickly. Now, this slide shows you an increase in the maternal mortality rates over a scope of 2000 to 2016. Now, this is a fact sheet which was given by the World Health Organization on maternal mortality rate. So 830 women die per day from the pregnancy and childbirth all over the world. 99% of the maternal deaths, they occur in the developing countries. and maternal mortality rate in the developing country is 239 per 100,000 live birth versus 12 per 100,000 live birth in developed countries. So you can imagine a gross difference between the healthcare facilities and the number of live births and mortalities in developed versus underdeveloped countries. Now, this is another WHO systematic analysis, which included the deaths of 61,000 patients. And they found hemorrhage, hypertensive disorders, and sepsis were the leading cause of the maternal death worldwide. Now, in this you can see this is the data from January 2014 to 2020, in which maternal mortality rate has been compared, and Pakistan, India, and Bangladesh. They have shown a reduction in the maternal mortality rate, where there's a significant increase in the Afghanistan, which has increased from 460 to 638 per 100 live births. Bhutan, there's not a significant increase, and in Nepal, it is also increased. This is a study which was basically this is data from various cities of Pakistan, which shows that hemorrhage is the leading cause of the maternal mortality in Pakistan as well. Now, this is another UK inquiry into maternal death, which shows that hemorrhage was the third highest cause of maternal death in 2003 to 2005, whereas in 2006, around 2018, a change in the ranking of the direct deaths by cause. So deaths from the hemorrhage dropped to 6th place. Previously, it was on the 3rd place. Now, South Asia data, it shows that South Asian countries like Pakistan, India, Bangladesh, and Nepal that are contributing major shares in the maternal death worldwide. Pakistan ranks 3rd highest in the entire world in account for the increased maternal mortalities, and we have 186 deaths per 100,000 live births. So why major obstetric hemorrhage is so challenging? Can any one of you come across with your previous experience or with the what knowledge you have? Can anyone write my answer? Why major obstetric hemorrhage is so challenging? That is APH and PPH. Why it is difficult to manage? I would like few of you to write down the answers in the comment chat box. G, anyone? Okay. So why it is challenging? Because the bleeding is rapid. At times, you come across with liters of bleeding within a span of few minutes. And this can be life-threatening if you're not prepared, if you doesn't have a blood in hand, if you are not well equipped, you doesn't have a good monitor in hand. Then the other problem is the estimation of the blood is very difficult. And the reason being that it can be difficult to quantify due to the dilution with the amniotic fluid. Then blood loss may be concealed. That the video I have shown you, you must have come across that there are a lot of blood on the floor, on the sheets, and then at time it's on the gloves, on the gowns of the and the sheets which are present on the legs of the patient. So it is difficult to estimate as well. Then physiological changes of the pregnancy, they mask the normal clinical signs of hypovolemia. So how would you, so basically major obstetric hemorrhage is divided into two components. One is the antepartum hemorrhage and other is the postpartum hemorrhage. So can anyone define what is antepartum hemorrhage? You can write down the response in the common chat box. I would like to know what is antepartum hemorrhage. I think all of us are working in the obstetric setups. So we must know what is antepartum hemorrhage. And what is postpartum hemorrhage? I'm waiting for the response. Out of 76 people, nobody knows what is antepartum hemorrhage. Okay. Antepartum hemorrhage is a pervaginal bleeding after the 24th week of gestation and just before delivery. And the common causes are placenta previa, abruption placenta, bleeding from the vaginal or cervical lesion, and the trauma of the uterus and uterine rupture as well. On the other hand, postpartum hemorrhage is defined as it is divided into two categories. It is the primary and the secondary. So any pervaginal bleeding which occurs within the 24 to 48 hours of the delivery of the fetus is known as primary postpartum hemorrhage, whereas the bleeding which continues for up to 6 weeks is called as secondary postpartum hemorrhage. So we have various causes for that. The uterine atonies stand for the 90% of the cases, then retained product of the conception, genital tract trauma, uterine inversion, they also count for the postpartum hemorrhage. Okay, so what is abruption placenta? Can anyone give me what is abruption placenta? So abruption placenta is actually a premature separation of the normally sighted placenta. So placenta is generally located at the upper and posterior portion of the uterus. So whenever when it separated prematurely, it leads to abruption placenta. And how it presents, it is actually a painful vaginal bleeding, which complicates about 0.5 to 2% of all pregnancies. So it is two types. One is the revealed or overt or external bleeding. So there is obvious external vaginal bleeding in 2/3 of the cases. On the other hand, there is another category which is called as concealed or internal bleeding. So in this, what happens is that bleeding occurs due to separation, but it is concealed and it doesn't come out of the vaginal tract. So this is a dramatic representation of this, what I have told you. Anyone who knows about the different grades of placenta previa? They are 4, 1, 2, 3, 4. So if you can write down what is placenta previa 1, 2, 3, or 4. Anyone, if you would like to write down? So we are getting some answers. 1 near the os, okay. 2 partially covering the os, no. 2 is approaching os. 3 is away from os, okay. Can we have more answers? What is type 3 and what is type 4? Good, good. So people are starting to move. Good. 4 completely covering. Okay. So we have 4 type of placenta previa. So grade 1, which is called as lateral placenta. The placenta implanted in the lower uterine segment, but it does not reach the internal os. So it is away from the internal os. And the grade 2 is the marginal placenta. So the edge of the placenta reaches the internal os. It is lying just close to it, but it is not covering it. Grade 3 is called as the partial placenta previa. The placenta is partially covering the internal os. And grade 4 is called as complete placenta previa, in which placenta completely covering the internal os. So grade 1 and 2 are called as minor placenta previa, whereas grade 3 and 4 are called as major placenta previa. One very important component for the clinician, obviously they are not doing it, it is the obstetrician who are going to do it. Whenever you have a suspicion of placenta previa, per-vaginal examination should not be done, because you're not sure about the position. At time on ultrasound, you can have a placenta previa 1 or 2, but actually it is placenta previa type 4. So whenever you do a pelvic examination, you might lead to extensive bleeding from the genital tract. So again, this is the grammatic representation of the different type of placenta previa. What is invasive placenta? Can somebody tell me? What is invasive placenta? Placenta accreta, increta, and percreta. So these are 3 types of invasive placenta. What is placenta? Can you write down What are these different type of placenta? Okay, good. Excreta. Then what is percreta? We have we are getting comments in the chat box. Yes, what is percreta? So just look on this diagram. It's clear to everything. So placenta accreta is one in which placenta is encroaching the myometrium. In increta, it goes into endometrium. And in percreta, what happens that it just goes through the uterine wall, ruptured it, and it is just embedded into the surrounding structures. The structure could be like it is generally what we have seen in a clinical practice. It is the intestine, it is the urinary bladder. At time, it goes back and invades the rectum. What is postpartum hemorrhage? And can you define what is postpartum hemorrhage and what is the etiology of the postpartum hemorrhage? Any one of you? Amina does very good. So we are getting. Okay, Etisham is very active. Good, wonderful. 4 Ps. Okay, so postpartum hemorrhage is defined as a blood loss greater than or equal to 500 ml within 24 after birth, while severe PPH is blood loss greater than or equal to 1500 ml within 24 hours. So this is a definition which is given by the WHO. So who has written 4 Ts? Tone, tissue, trauma, thrombin. Wonderful, Amna Ijaz. Thank you very much. So look at the etiology. So the etiology of the PPH lies in these 4 Ts. So number one is the tone. So it is basically the abnormality of the uterine contraction, and uterine atony stands for 90% of the postpartum hemorrhages. Trauma. It is actually done during the process of delivery. So it could be due to instrumentation, it could be due to the cephalopelvic disproportion, or it could be due to the uterine version or uterine invasion. Then the third is the tissue. It is basically the retained product or at time abnormal placenta, which is the placenta previa or placenta abruption. And then finally is the thrombin. So thrombin could be due to coagulopathy, as it is common in the abruption placenta, or it could be due to therapeutic anticoagulation. So these are the different, if you remember all these 4 Ts, so this will give you the etiology of the primary PPH. I'm not going into the details of the hemorrhage and its degrees, because all of you know that, with the increasing hemorrhage, these are the findings: generally tachycardia, mild hypertension, vasoconstriction, oliguria, then anuria, and at times centurium is disturbed. So I'm not going into the details. Now we come to the management component of this obstetric problem. So how to approach a patient with major obstetric hemorrhage? So this is a guideline which is given by the NHS, how they manage their patients. So can any one of you write down there, how will you approach a patient who has presented with the antepartum hemorrhage? So I'm waiting for the responses. Amina, Ahmed, they're very active. Saif, good. Early recognition of the signs. Yes, can we have multidisciplinary approach? Wonderful. Call for help. Whiteboard IV lines. Yes. Ultrasound. Very good. Very good. And it's a slide. I'll give you this presentation later on. Don't worry about that. ABC. Wonderful. Excellent. That's a transfusion protocol. Blood. Wonderful. So let's see cross-match investigations. So whenever you have a crisis situation, we start with the call for help. So generally, in this scenario, when you have a patient with APH, we are the help. Basically, we are the help, we are called by our obstetrician colleague. So you always start with the ABC, that is airway, breathing, and circulation. What you do is you provide them with the supplementary oxygenation, and you go and obtain intravenous lines. ideally you should pass 2 wide-bore IV cannulas, and you will start the intravenous replacement of with the crystallite solution, colloid, or whatever solution is available. You have to maintain the blood volume. Then you apply certain monitors and you start monitoring the vital sign, catheterize bladder, and monitor urine output. So you'll have to assess the need of blood transfusion at this particular point, and you will send the lab test. So generally what we require, these are generally young patients, so we need CBC, complete blood count, we need blood group, we need cross matching, and we need coagulation profile. So we'll have to go for these, and obviously we can go for additional investigation as well. So it all depends from situation to situation. Now this is basically a slide which shows you, once you come across this kind of problem, how to manage the patient. This is basically a PPH slide, how to manage the PPH. So ready to refer, if you don't have the facility, you must have a referral center in the nearby hospital. The type of drugs which can be used to control PPH is the oxytocin, ergometrine, prostaglandins, and tranexamic acid. Then you can go for uterine massage, then bimanual uterine compression, external aortic compression, intrauterine balloon devices, and finally you can shift the patient to OT. So apart from drugs, rest of the things generally they are taken care by the obstetric colleagues. So what is new in the practice? These are called as maternal safety bundles. Again, this is data which is taken up by the NHS guideline. So anyone of you who know about the obstetric hemorrhage safety bundles? Anyone have this idea? Ji Ahmed Qureshi? No, you don't have any idea. Basra Durrani. Okay, so we just go through this obstetric hemorrhage. Okay. So these are basically 4 R's. So these 4 R's are readiness, recognition, response, and reporting. Okay, so readiness in every unit. Every unit must have this readiness. And how you do it? You prepare some transfusion protocols. You must have a hemorrhage card. You must have a hemorrhage response team, and you must be going through different simulation and team drills so that whenever you come across a situation, you shouldn't be in a panic situation. The second is the recognition and prevention for every patient. What is this? Basically, this is the job of the obstetrician to identify the perinatal risk assessment, prompt diagnosis of the causes, assessment of the blood loss, and active management of the 3rd stage of the labor. Then response for all bleeding patients. Again, this is the responsibility of all the units. So they can have a call system, logistic and communication. They should be in close liaison with the rapid response team, multidisciplinary approach, role assignment, utilization of the checklists and protocols, reevaluate etiology, labs, blood, and etc. Then finally, the most important component, which generally we are missing in our setups, and particularly if we talk about Pakistan, is the reporting and learning for all the units. The culture of reporting is very, very important for all these incidents, and then culture of debriefing. What problem we have faced in the last time, so we should not come across with these kind of problem in the next coming. Then multidisciplinary review. All of the teams which were involved in the management of these patients, they must have review their protocols and what were the outcomes. So these are 4. These are called as. So this is the. Okay. So this is the first response PPH. This is the first response PPH means that is PPH. There's a conventional PPH. PPH occurs and I think we'll have to mute the mics. There's a certain disturbance. Can we mute the mics? Okay. So first response PPH bundle, what you do is you will have to manage the volume with the crystallite solutions. You'll go for the uterine massage. You can use uterotonic drugs and tranexamic acids. What is the dose of tranexamic acid which is recommended, and what are the different urotonic drugs which can be used? Can you write down? 1 gram 8 hourly. Okay. 10 mg per kg. Okay. Or Saeed Hussain. And if we have to repeat the dose,
2 grams are loading dose. Yes, we have to give the infusion. First, we have to give like 2
please
grams
write down
start dose,
instead
and
of
we have to give
talking.
in 8 hours.
Okay, I would request to please write down in the chat box instead of using the mic. Okay, how to manage the refractory PPH bundle? How to manage the refractory PPH? So we have a bundle for that as well. There's a compressive aortic compression or bimanual uterine compression, intrauterine balloon tamponade, non-pneumatic anti-shock garments, and then a continuing dose of the uterotonic, for example, oxytocin diluted in the isotonic crystallite, and a second dose of tranexamic acid should be administered during the application of this bundle. So this is basically confined for those cases where there is refractory PPH. Again, most of these are conducted by the obstetrician. We are just concerned with the medication. So British committee guidelines, what they say. So they endorse that you have to maintain a therapeutic goals of the management of the major obstetric hemorrhage, which is you have to maintain a hemoglobin of more than 8 gram per deciliter. The platelet count should be more than 75,000. INR should be less than 1.5, and fibrinogen level should be more than 1 gram per liter. Can anyone of you write down the importance of fibrinogen in a postpartum hemorrhage patient or in a patient with a major obstetric hemorrhage? What is the importance of fibrinogen? Yes, Ahmed Qureshi, to prevent DIC. Okay, okay. What is shock index? Can any one of you have any idea what is shock index? G. Can anyone write down about what is shock index? So shock index is basically the ratio of the heart rate to systolic blood pressure. So studies have demonstrated that high mortality is seen despite minimal changes in the vital sign in hemorrhagic shock and trauma patient. So this was first time practiced in a patient with trauma who presented with the hemorrhagic shock. So a shock index of more than 1.1 may result in significant increase in the massive transfusion and mortality rates, whereas a shock index of more than 1.3 may lead to 5-fold increase in the massive transfusion and mortality. So shock index may be beneficial in the obstetric hemorrhage where BP and heart rate are considered within normal range. So what happens due to, as I mentioned earlier, that due to physiological changes of the pregnancy, at time it is difficult to assess the hypovolemia in these patients. So with the help of this shock index, you may be able to identify your patient is going in a danger zone. So you can prevent that. So what they further state that think about the early administration of the fresh version plasma, and the ratio can vary between 1:1 and 1:2. So it all depends upon the institutional protocol. In certain units, they go for with 1:1:1. In other units, they go with the 1 RBC, 2 RBC, and 1 FFP. So it all depends what is your institutional protocol. Decreased fibrinogen level is the earliest finding in the major obstetric hemorrhage coagulopathy. So this is very, very important, and that's why it is said that the level should be maintained somewhere around 2, which is the normal level. That platelet count, PT and APTT, they did not predict the obstetric hemorrhage induced coagulopathy. So at times, if they are not, you cannot rely only on these tests. Presence of metabolic acidosis is a strong predictor of the morbidity as well as mortality. Change the outcome of this kind of a patient who is presenting with the major static hemorrhage. Can we have certain answer here? Sayyid Hussain, Mohammad Imran, Sayyid Hasnan, Said, Ahmed, Istisam, G. How anesthetist can help in the major obstetric hemorrhage? So we don't have any answers. Okay. So what we can do as an anesthetist, if you are called for help, you will be able to recognize and prompt resuscitation early, which perhaps may be missed by our obstetric colleagues because they are not trained the way we are. Immediate identification and treatment of the cause, that portion is to be taken care by the obstetrician. Communication with the blood bank and senior help should be requested, including the senior obstetrician and senior pediatrician. Then you must have a senior surgical and urologist to help in these type of cases. The hematology services should be alert, inform ICU, and book for this patient. What you can do is, in addition, you can go for IV access, oxygen supplementation. You can go for the ABC, blood for counts, coagulation, and cross-matching should be sent. Monitoring like pulse, BP, ECG, pulse oximetry, urine output. Even if it is required, you can go for the invasive arterial monitoring and central venous light. So if you have the facility of a point of care device like HemoQ or TEG, that would be great help in these. So we have certain answers here by Dr. Arbab and Sarah Jamal. Thank you very much. Okay, so coming to the management, what else we can do? All flights should be warmed, and rapid infusion devices should be present. Whiteboard cannula and level 1. And any one of you have an idea what is level 1? It's a rapid infusion device. Can somebody answer me? What is level 1? Level 1 is actually a device. Okay, so basically level 1 is a device which gives any fluid. Generally, it gives 500 ml of fluid within 3 minutes. And the beauty is that all the fluid which is given, either it is blood or it is simple fluid, crystalline or colloid, it is delivered at body temperature. So the problem of a lethal triad, which is the acidosis, hypothermia, and coagulopathy, it is prevented by using this device, level 1. The choice of the fluid could be crystalline, colloid, blood. It all depends in which situation you are working and what are the facilities available. Avoid delusional coagulopathy. So think about giving blood and blood products early in the management. Fully cross-matched blood is ideal. If you have fresh blood, then you can then you are in a better situation because you have all the coagulation factors and platelets which are available in the fresh blood. And can anybody write what is fresh blood by definition? For how long once the blood is taken out from a donor, it is called as fresh blood. Okay, over-aggressive can be used in case of non-availability of the group-specific blood that we all know. So 6 hours, yes. 6 to 8 hours. After 6 to 8 hours, if blood is not, if the blood is given, most of the coagulation factor and platelets are gone. So once the blood is taken out from the donor, if it is transfused within 6 to 8 hours to a patient, it is considered as fresh blood. A reuse of FFP, what we have already discussed, fibrinogen replacement if required in case of coagulopathy, then 1:1:1 ratio for red RBCs, FFP platelets, and target for a platelet count of more than 75,000. So somebody write about the radiological management. So this is how you can manage these cases. If you have if you have a placenta perpetuita already on board, so what you can do is if mother is hemodynamically stable, you can go for a intra-arterial uterine catheterization is done preoperatively in the radiology department, and the embolization requires fluoroscopic guidance and availability of the interventional radiologist. So it depends what kind of facilities where you are working. And recombinant factor 7A. Any one of you have ever used this which is called as Novo 7, that's a trade name, in your clinical practice for any kind of uncontrolled hemorrhage? By chance, I have used this Novo 7 for 4 patients. 2 were obstetric. One was the bladder tumor, and the other was a patient of thoracic surgery. So basically, sorry.
Bed number 1 बाट वाला नहीं है.
Please can you switch off your mics and write in the chat box. Yes, Dr. Barsa Durrani has asked that we haven't used factor 7. Yes, it is available in Pakistan. So recombinant factor 7 is used for the treatment of the uncontrolled obstetric hemorrhage, massive hemorrhage which is not responding to conventional therapy. It promotes coagulation. Effectiveness is diminished in acidosis and hypothermia, so we'll have to rule it out. And its initial dose is 90 microgram per kilogram body weight, and it can be repeated after a couple of hours. Fibrinogen concentrate, this is something which is new in the practice, and what is the rationale for use is lower level of less than 2 gram per deciliter. They are predictive of severe PPH. So this should be considered when you are dealing with a patient of severe PPH. And basically, it is the final substrate in the coagulation cascade. So decrease to 40% may result in massive bleeding, and it is necessary for the platelet aggregation as well. So it is safe, inexpensive, and it has a longer shelf life. So 1 gram increase in the fibrinogen level require 60 milligram per kilogram fibrinogen dose. So you can remember this for your vivas and for your clinical practice as well. And we come to the tranexamic acid, which has been added into the practice in 2016. It should be used where increased fibrinolysis is anticipated. Initial dose is intravenous bolus of 1 gram, followed by 1 gram 6 hours, and can be used up to 4 hours. Like if the dose is 1 gram 6 hours, 6 hourly, but if it is massive hemorrhage, you can use it 1 gram 4 hourly as well. Then comes to the prostaglandins, carboprost. It is 0.25 milligram dose can be given intramuscularly and repeated to a total dose of 2 milligram. The obstetricians are very fond of giving this in the intramyometrial administration. It's off-label use, and what we have seen that it leads to severe anaphylaxis at time, bronchospasm, hypertension, and pulmonary hypertension. So whenever you are using this drug, and particularly if you have a patient with respiratory disease, you should be very, very careful. Intraoperative cell salvage, it can be used for high-risk cases where you have limited blood facilities and the patient who have objection to allogenic transfusions. Misoprostol is commonly used, what is called as prostaglandin E1 analog. Surgical management, I am not going into the detail because it's the job of the obstetricians. So these are the different guidelines with the FICO recommendation on postpartum hemorrhage in 2022. One is the prevention and management of postpartum hemorrhage. It was a nice guideline. The other, this all presentation is basically revolve around these 3 guidelines. So I'll give you the latest which I've got. This is the updated WHO PPH recommendations. So PPH recommendation was given first in 2012, and it was for the prevention and treatment of the PPH. Then in 2016, it was modified, and in 2017, in response to a new evidence women trial, WHO updated the recommendation on tranexamic acid for PPH treatment. In 2018, in light of new evidence, WHO champion trial, the recommendation on uterotonics for PPH prevention were updated. In 2020, 4 recommendations was made. One is the urinary UBT for the treatment of the prevention. Basically, it is the condom catheter which is placed in the uterine cavity with some, it is filled with some liquid. Then is the umbilical vein injection of oxytocin for the treatment of retained placenta. Then the third one is the route of oxytocin administration for the prevention of PPH after vaginal birth. And then is the advanced misoprostol distribution to pregnant women for prevention of the PPH. So these are the WHO recommendation. So these are just, I'm just passing through these. This you can have a look on this one. Effective uterotonic for the prevention of PPH during the 3rd stage of labor. So what we have experienced and what we have gone through, that gradually we were decreasing the dose of oxytocin to from 10 units to 5 units and then 5 to 3 units. So again, the recommendation is you can use this 10 unit of oxytocin, intramuscular or intravenous, and it can be repeated in the form of infusion as well. In setting where oxytocin is unavailable, the other ergometrin or ergometrin can be used, or ergometrin fixed dose combination and with oxytocin can be used, and oral misoprostol is also recommended. So its doses in certain center it is used as 400 microgram, or it can be used as 600 microgram. It can be given per oral or per rectal. This is the algorithm. I'm just skipping it. And next we come to the how to anesthetize these patients. Gee, I'm sure we have 87 participants here, and everyone have come across some kind of APH, PPH patient or patient of major obstetric hemorrhage. So what is your line of action? How do you proceed in these situations? Anyone who want to answer can open his mic, and we can have their view. Then I'll show you the slide. Jeep.
Rapid sequence.
Anyone wants to speak? Jeep.
Rapid sequence induction with ketamine.
Rapid sequence induction with ketamine. Okay. थोड़ा सा ऊंचा बोले.
कि पेशेंट वाइटली स्टेबल है या नहीं है. अगर वाइटली स्टेबल है तो वी विल इंड्यूस विद प्रोपोफॉल, आरएसआई करेंगे, और अगर वाइटली स्टेबल नहीं है तो फिर हम केटामिन देंगे, उसको आरएसआई करेंगे.
ओके, व्हाट एल्स?
सर सबसे पहले पेशेंट का लिए मशीन चेक करेंगे, इमरजेंसी ड्रग्स रेडी होनी चाहिए. उसके बाद आपने लोकल में कोशिश करना है ए लाइन ले लें, हीमोडायनामिक इन्वेसिव मॉनिटरिंग करके फिर आपने इंट्यूबेशन की तरफ जाना है. उसमें आपने पेशेंट के वाइटल्स लेके फिर ड्रग ऑफ चॉइस देखनी है क्या. अगर पेशेंट जो केटामीन है उससे इंडक्शन करनी है या वो विद सक्स.
ओके,
एबीसी करेंगे उसमें.
और क्या करेंगे?
सर्कुलेशन, एयरवे ब्रीथिंग सर्कुलेशन को देखेंगे, पेशेंट के रिस्पांस के इसको देखेंगे, और इज द पेशेंट रिस्पॉन्सिंग टू द रिससिटेशन. और अगर पेशेंट को पेटेंट एयरवे चाहिए तो हम ईटीटी पास करेंगे, अदरवाइज वी विल गिव 100% ऑक्सीजन विद नॉन रीब्रीथिंग मास्क. एंड
सर इन सारी चीजों के साथ हमने ब्लड अरेंजमेंट भी कराया.
And
good blood arrangement. Okay, what else?
और
Very important.
two
मैंने
more
आपको
IV
lethal
lines.
triad का जिक्र
Level
किया
1.
था.
presence of senior
The 2 more
obstetrician.
IV lines. Level 1.
Chale, thank you very much. So can you please put off your mics and we just have a look. So अब यहाँ पे ना आप लिख दीजिएगा. So number 1 is, would you like to go for GA or regional? If I say it's a placenta previa type 1 or type 2, so would you like to go for GA even, or 3-4 method? There is no question of regional. Yes, regional. Okay, Sadia Riaz say that they'll go for GA, even for type 1 and type 2. Okay. It all depends again on your institutional protocols. There are certain centers which proceed with the placenta type 1 and type 2 under regional anesthesia. But for the examination, I would suggest that GA is the safest answer. So what you are looking for? The most important thing is the consent, because you will be having a patient who is a healthy patient otherwise. So you'll have to go for certain. You'll have to go for a consent, which we call as a high risk consent, high risk informed consent, in which you're going to tell them about there's a possibility of hysterectomy, there is massive hemorrhage, and you need to have multiple transfusion and blood products, and there's a possibility that patient might end up on a ventilator and will stay in ICU for unlimited period. There might be a need to involve other consultants from various disciplines. Most of the time, this consent is taken up by the obstetrician, but what I would suggest you and the ones who are working in Pakistan, they must know about the MSDS protocols. So anesthetist must get his own consent with the family. I strongly endorse that you must talk to family. You must talk to family about this high risk consent. Don't leave it to obstetrician. So we'll start with for any patient what we are for which we are whom we are managing, we go for standard 1 and 2 monitoring to start with. Okay, so for this kind of patient where you're anticipating a massive loss, I would strongly endorse that we must get an arterial line under local anesthesia. And even in certain cases where you are anticipating a heavy loss, you can put a HD catheter. HD catheter is hemodialysis catheter, so you can rapidly transfuse. So if you have a facility of TAG, which most of us, we don't have in Pakistan at the moment. So if you don't have this, you can go for Hemmorhage. Hemmorhage is a monitor. It is just like a pulse oximeter, and it gives you a continuous monitoring of the hemoglobin throughout the procedure. Then serial sampling should be done regarding hemoglobin, hematocrit, arterial blood gases, and clotting profile. I'm not going into the details of the induction. All of you know how to do it. So I'm just kicking you the important points. So temperature is very, very important in this patient. As I was telling you that we might come across a problem of lethal triad. So you'll have to control the temperature. That can be done by warm blankets, controlling the operation suite temperature, and then giving the fluid and blood in a blood warmer. Then you can have hemodynamics for rapid IV infuser, level 1, vasopressor support. At times it is also required. Then emergency backup for the blood product backup, and drugs. And you'll have to have a communication with the obstetric team, surgical team, and the blood bank. So when you going to put this patient in the postoperative period? So ideally she should be, depending upon how the case ends up, patient can move into the high dependency unit or an intensive care unit, and you will have to go the serial assessment of the hemodynamic monitors, ventilatory parameters, temperature, hematocrit, electrolyte imbalance, coagulation profile, ABGs, urine output, pain control, etc., etc. And then you'll have to look for the blood products, what is required, and you're going to treat patient with the help of blood and blood products, depending upon the situation and obviously the care of the ventilation. This is a protocol which we made, and it is close to a protocol which is followed in the UK. This protocol was for a private hospital where I used to work, and as I mentioned you earlier, that we come across a patient who bled 37 liters, and she was reopened 3 times and finally was managed with the tranexamic acid. So in this, we made a protocol which was so complicated pregnancy to be dealt by a senior consultant. So the SLs, they were not allowed to handle with the invasive placenta. 4 cross-match unit should be along with the patient in the OR, particularly if you are talking about placenta previa type 3 or type 4. Then we were using invasive monitoring and hemoglobinometer. that's called as HemoQ, which is the point of care device. Fluid warming devices and pressure infusers, we have level 1 in that institution as well. Coordination with the blood bank and senior surgeon, and presence of the general surgeon and urologist at the time when surgeries were conducted. Early design of the hysterectomy, and you will be surprised that anesthesiologists were also involved in the decision making of hysterectomy. SSP bleeding continues and oozing continued, and then send ABG's coagulation profile. So this was the protocol which we designed for that particular hospital. Now, this is a simple trolley, and all of you, I would strongly suggest and endorse that all of you must have this kind of a setup in your theaters where you are working. Now you can see from 22, 20, 18, 16, 14 cannulas. Then we have an arterial line. Then we have this roll for putting the arterial line. Then this is the HemoQ, which is the white, this white sticker-like thing. And then you have the various CVP, large port syringes, and your BT sets, etc. This is the infusion bags which can be used. This is the HemoQ. It gives you the continuously give you the saturation as well as the hemoglobin of the patient. This is a relatively simple and cost-effective monitor. Blood bags, they're contained in a proper container. Now this is the arterial line, and that's how we used to warm the fluid. This is a 1 liter saline bottle. You cut it, and it is filled with the warm water, with the hot water, which is generally we do from the kettle we use for the tea making and coffee making. The arterial line you can see, and these are the different guidelines which are managed in various parts of the world. This is again from the UK, and this is again from another center. And this was the one which we made in our institution, in our hospital. So just to conclude, maternal hemorrhage remain one of the leading cause of maternal morbidity and mortality, and it is worldwide. It is not just confined to developed countries, but developing countries, but also in the developed countries. So you must have protocols. Protocol must be developed to timely assess and manage obstetric hemorrhage. Audit should be conducted in every department to determine the incidence factors, and you must have dedicated teams to must be developed to deal with the obstetric hemorrhage. To summarize it, early patient evaluation that has to be done by the obstetrician and by the surgical team, call for early help and this communication. You must have a multidisciplinary approach, serial labs, use of the blood and blood products, activate passive transfusion protocol, use of invasive monitoring, post-op ICU care, and monitoring approach. Thank you very much. So this was a statement given by the Lancet. I love this picture and this caption: no woman should die giving life. Now coming to a clinical scenario. So you can read this clinical scenario. So a 32 years Jodat 3 presented in the labor room with history of heavy PV bleeding for last 6 hours. She is not a booked case. This is a common scenario in public sector hospitals. Her presenting vitals are blood pressure 80/50, pulses 140 per minute. She has a respiratory rate of 32 per minute and with a saturation of 92%. You have been called by your obstetric colleagues to help in the management, and they want to operate this patient on urgent basis. So how will you proceed? Who's going to answer, or would you like to, like a couple of people can answer this? You can open your mic and you can start. And after this exercise, if you have any queries or questions, I'll try to satisfy you by giving your answers. So who's gonna manage this case? Call for help. Okay, man. I have Atia Latif. Thank you, Athiya. So she says she is going to call for help. She'll do ABC, whiteboard IV lines, blood for rubic cell. History, pre-op checkup, investigation, very good. Attached monitor, IV lines, very good. Prepare fluids. Management, resuscitation, evaluation, go side by side. This is the wonderful answer, Dr. Ahmed Qureshi. This is a typical answer which all your examiner, they expect from you. Informed consent, very good. Whiteboard IVs, high risk consent, senior help in terms of obstetrician as well as the anesthetist. Okay, arrange for the blood products. Level 1, if you have this facility, okay, arterial line, multi-stream management, blood arrangement, activate method transmission protocol. Excellent. Anything else? Inform the OT for high risk surgery. Okay, where you gonna take this patient after the surgery? ICU. Wonderful. So you'll have to book a patient, book a bed as well. Okay, okay. Call for urologist, general surgery, post ICU care. Excellent. HDU. Okay. If you're able to extubate the patient and she's fine, yes, she can be kept in the HDU. Okay. Any other answers? Any other suggestions? How will you maintain the temperature? Need to resuscitate first. Okay, very good. The patient has been bleeding, so you'll have to check with your obstetric colleagues at how much she has bleed. So you'll have to resuscitate the patient. Very good. Send labs, temperature monitoring, high risk consent, blood bank backup, warmers, inotropes, warm blanket, warm fluids. Wonderful. Eutotonics, thromboxanic acid, send labs, vascular surgeon, intervention radiologist after resuscitation. Yes, it can be done, but again, as I mentioned to you that in most of the centers in Pakistan, we don't have a facility of intervention radiologists. So this is kind of an emergency case. The intervention radiologist can play a role if you have a planned and scheduled case. All pediatricians, yes. Monitor you to avoid AKI. Good. Okay, thank you very much. Thank you very much. I hope you find something different from
vascular
this
surgeon and
presentation.
interventional radiologist after all years fail, sir.
Sorry. Avoid lethal, try it. Amen, Nasser. Okay, thank you. Yes, wonderful. Avoid lethal, try it. Okay. Do you have any question or queries?
Ligation of internal ileus or hysterectomy, these can be planned. But if these
Yes.
fail eventually, then
Gee, I was asking if you have any queries or you want to clarify anything, or I was not able to convey you.
इसमें internal ileus ligation है सर, वो तो कर सकते हैं इसमें सर.
बिल्कुल कर सकते हैं, बिल्कुल कर सकते हैं. इसमें देखें, actually that is a surgical portion in which Behling suture can be applied. Then they can go for ligation of the uterine artery or internal carotid as well.
From anesthesia point of view, we'll follow the massive transfusion protocols.
Yes, yes. Etisham has asked use of adrenaline and uterine bleeding. Role of adrenaline, like you were asking for an intravenous bolus or direct injection into myometrium. Dr. Etisham, you have raised a question. इसकी PPT share करें please. Okay, okay. I'll send it to.
जी सर, मेरा क्वेश्चन ये था कि जो सर एड्रीनालिन है सर, उसका जो रोल है इनटू मायोमेट्रियल इंजेक्शन, अगर हम इसको देते हैं तो उसका कोई रोल है इसमें?
Not to my knowledge. I haven't seen any obstetrician doing this. Instead, they use carboprostol. It is again an off-label use. Carboprostol can be used intramyometrial, but it leads to severe vasoconstriction, hypertension, and bronchospasm. So particularly if the patient is asthmatic or with some underlying respiratory disease, it should be used with very, very careful cautions.
Thank you, sir.
सर रोल ऑफ ऑक्सीटोसिन इन शॉक सर हम कितना वो तो अवॉइड करेंगे सर थोड़ा बहुत
Role of oxytocin in
शॉक पेशेंट सर शॉक में जब होगी सर
अच्छा इसमें देखें रोल ऑफ ऑक्सीटोसिन इन शॉक पेशेंट ये है कि जो रिकमेंडेशन है आपकी आई वाज टेलिंग यू दैट वी स्टार्टेड विद द with 10 units of oxytocin, and then we used to give 40 to 60 units in every drip for like next 24 hours. This was the practice like 10-15 years ago. Then we keep on decreasing the dose of oxytocin to 5 units, and finally we come to 3 units, just 3 units stat of oxytocin. Now, in this WHO recommendation, they have stated that you can go for 10 units of 10 units of oxytocin, either intravenous or intramuscular, or you can use in further infusion. Whatever infusion you are using, you can go for. They have encouraged the use of oxytocin, despite the fact that it leads to vasodilatation and tachycardia as well. So if you talk about the recommendation, yes, it can be used. But on the other hand, our previous experience says that it should not be used. But generally, we should go with the guidelines.
Thank you, Dr. Jodat. We have Dr. Arshad Taki with us and Dr. Akhtar Wahid. First of all, I will request Dr. Arshad Taki if he could please comment or give us some additional point if you are listening.
Gee, of course, I'm listening and I've been listening. I joined a little late, but of course, after Dr. Jodat's lecture, there is hardly anything that I can add. He's a master. But from my side, all I can say is that all obstetric hemorrhages are not the same. So you could have anything from mild to moderate to severe. And as Dr. Jodat has pointed out, we have experienced some pretty extensive hemorrhages, which we were fortunate to kind of manage successfully. There are two fundamental things, of course, volume replacement, but of course, too aggressive crystalloid-based resuscitation may end in coagulopathy. So we have to switch to blood and blood products as soon as possible. Dr. Jodat actually talked about what is written in the guidelines, which is giving factors of kind of blood components. But in our society, we tend to give whole blood. And I have found that to be amazing if we have our hand to it. In all the hemorrhages that we talked about, we were administering whole blood with the donors and they lined up and we getting the fresh blood. In that case, what we have done is we checked the prothrombin time serially, and we found that patients who were giving fresh whole blood had hardly any need for FFPs. The second most important thing is to avoid acidosis, and the third, and I think even more than anything else, is to avoid hypothermia. So that's my 2 pence on it, and it was a great presentation, I must say. Lots of teaching points that I have taken. Thank you.
Thank you, Dr. Arshad. Dr. Akhtar, could you please tell us what, in your time, what you used to do? Nowadays, we have so many sophisticated and modern equipment and drugs, medications as well. So could you please share your experience?
If I tell you my experience, back in Eastern Medical College, Multan, such cases we used to use open heater in the mask, Shimil Bush's mask. Can Dr. Jodat think about it? And those patients used to survive. In Eastern Medical College, Multan, which was the second medical college in Punjab. Anyway, that's besides the point. Now, whatever you have mentioned, Dr. Saab, about the warming of blood and everything, that is everything I have seen in Karachi, in SIUT, what you know, the urological center here in Karachi. And it's very easy, but what I would say now, that I have thoroughly enjoyed there are many things I had forgotten because since 2004, I have not done any obstetrics. Anyway, I'm retired now. I'm not doing any work since 2020. I'm totally retired, but I've thoroughly enjoyed. That's what I want to say. What else I can say? But I never miss your lectures. What Asma is arranging, I request her. It was a wonderful presentation. Thank you very much. I enjoyed that. There's so many things, fresh frozen FFP and this and that and whatnot. Everything just came back.
Indeed, it was a very insightful talk. And now we have, thank you, Dr. Akhtar. Dr. Amin Khwaja is with us, who is the PSA Karachi chapter president. Dr. Amin, could you please give the closing comments?
Ji, Assalamu alaikum. Thank you very much. I'm the past president. Dr. Jodat talk almost covered everything. I listened his talk and he is updated, and he is the good thing is that he has presented in the scenarios, so it is good for the students who are appearing in the exam, and it is easy to understand how he presented his talk. So thank you, Dr. Jodat, and thank you to all our senior colleagues, Dr. Arshad Taki Saab, Akhtar Wai Saab, and all other seniors who participated, and they have given their feedback. Thank you, Dr. Jodat, for preparing this lecture and updating all of us. Thank you very much, sir.
Thank you, Dr. Amin. And let me inform all the participants that this lecture or discussion will be uploaded very soon on the YouTube channel as well. And I'm really very thankful to Dr. Jodat Saleem for sparing his precious time and such an insightful talk. Really very impressive. Thank you, sir.
Assalamualaikum.
Thank you, Dr. Jodat.
Thank you, ji.
इंशाल्लाह फिर मुलाकात होगी इंशाल्लाह.
Inshallah. Okay,
Thank you.
Allah Hafiz.